right, thanks very much, Ruben. So yeah, the title of my talk is there a role for JAK inhibitors in essential thrombocythemia? These are my disclosures. We will be talking about potential off-label use of ruxolitinib for ET. Okay, so I'd like to start with a case presentation. 72-year-old man presents with headaches and TIA symptoms. His past medical history is notable for hypertension and depression. He generally feels well otherwise. His physical exam, he does not have splenomegaly. The CBC shows a platelet count of about 1 million. He's JAK2 negative. He's positive for a Calreticulin mutation. And his bone marrow shows characteristic features of ET, megakaryocytic hyperplasia, minimal fibrosis. Cytogenetics are normal, and he's diagnosed with ET. So the patient initially is treated with hydroxyurea, but he develops anemia as hemoglobin goes down to about the 9 to 10 range. And his physician then changes him to anagrelide, but that is then discontinued due to worsening headaches and palpitations. So I have a question here. Go ahead and put your answer in. What treatment do you recommend for this patient? And we'll readdress this at the end of my talk. Pegylated interferon, busulfan, hydroxyurea. Even though he had anemia, maybe you'd put him back on hydroxyurea for lack of a better alternative, or off-label ruxolitinib. Okay, so at this point, about half of you are choosing pegylated interferon and about 40% ruxolitinib, and a few would reluctantly go back to hydroxyurea. So again, we'll discuss this more at the end of the talk and see if your answers are still the same. Okay, so I think, when we're thinking about treatment options for ET, the first thing we should really consider is what are the goals of therapy? And this is the ELN criteria, response criteria for ET, perhaps strictly speaking more relevant for clinical trials, but I think this is a good illustration of the various things we would consider as treating physicians. So, if you go through the criteria here, you would have, in an ideal situation with a complete response, you would want all disease-related signs to disappear, including if the patient has palpable hepatosplenomegaly, symptoms to go away, you want the counts to normalize. Of course, no evidence of progression, and also any hemorrhage or thrombosis due to the ET, and the bone marrow to morphologically go into remission. That's your best case scenario. Partial remission by the ELN criteria is essentially the same criteria except the absence of bone marrow histological remission. And of course, worst case scenario would be progressive disease. So you can think about those things in factoring in the different options for treatment. As far as considering the treatment options, for quite some time, there's been a relatively simplistic risk-adapted therapy sort of algorithm that's been proposed, and that's really based on risk of thrombosis. So low risk or high risk for thrombosis based solely on two factors, age and history of thrombosis. So to be considered low risk, you have to be both less than 60 and have not had any history of thrombosis. And for those patients, the standard recommendation would be low-dose aspirin alone with no cytoreductive therapy. So in other words, if you have a 50-year-old patient who has not had thrombosis and has a platelet count of 850,000, you're not going to put that patient on cytoreductive therapy, but rather just aspirin alone. High-risk patients, either age greater than 60 or history of thrombosis, then cytoreductive therapy would be added into low-dose aspirin. And again, that's relatively straightforward. But more recently, I think we're getting a little bit more refinement, at least in understanding the risks or the risk stratification, whether that has been validated in terms of the treatment options. I think that's less clear. But here's one example, the IPSET thrombosis score that was published a few years ago, where in addition to age and thrombosis history, 2 additional risk factors were added, which is any cardiovascular risk factors and the presence of JAK2 V617F. And you can see that JAK2 positivity actually gives you 2 points. So it's a significant risk factor, and that's, I think, pretty well established that those patients with ET who are JAK2 positive have a higher risk of thrombosis. And then the cardiovascular risk factors, which was a little bit amorphous in terms of how to consider that in the risk stratification, now is added in to this scheme. And if you look at the bottom here, which is probably a little hard to read, but the overall point here is that if we use the standard risk categories, low and high risk on the left here, but then divide those up by the new IPSET thrombosis score, which creates 3 categories, low, intermediate, or high risk based on the total number of points from above, you actually can see that, for example, within the formerly low risk category, the risk of thrombosis can range actually from 0.59% per patient per year up to 1.77. So the point is that these categories by the standard criteria are actually fairly heterogeneous, and that you can actually resolve this to a little bit better clarity with this updated risk stratification scheme. Again, it's not validated, though, in terms of saying, well, if they're low risk by or intermediate risk by IPSET thrombosis, that should change your treatment plan. So, again, JAK2 positivity is clearly associated with higher risk for thrombosis, and then by extrapolation, it makes sense then that Calreticulin positivity is probably lower risk, given that the majority of the JAK2 negative patients with ET are, in fact, Calreticulin positive. And that has been formally demonstrated in several studies. Here's one example looking at thrombosis-free survival on the left here, and you have your JAK2 mutant patients here and a clear separation with your Calreticulin mutant patients. So Calreticulin mutant patients clearly have a better prognosis in terms of thrombosis. Overall survival is not changed, but that is in part due to the fact that in general patients with ET live for quite a long time. But again, Calreticulin patients less risk for thrombosis. And that has led to a variety of proposed revisions to this very basic treatment algorithm based on risk. And here is one proposed example where in one point is that those patients who are low risk by the standard criteria, subdivide those into either JAK2 wild type or mutant, and those JAK2 wild type patients, again, mostly Calreticulin positive, the question is whether these patients should even be on aspirin at all. And the one practical reason for this to be considered is that although it's low-dose aspirin, they could be potentially at risk for bleeding events. And so if it's a young patient who's Calreticulin mutant, you might not do anything, actually. On the other hand, if you've got high-risk patients, generally it's still considered that cytoreduction is advised, and then you have your choice of a few different options, which we'll go into detail in the upcoming slides. And then for those patients who are considered hydroxyurea intolerant or resistant, the question is what to do there. So let's talk about hydroxyurea resistance and intolerance for a second. So these are the ELN criteria that have been put forth, and you can basically be defined as resistant or intolerant to hydroxyurea by meeting any of these criteria. The first is if you're on a high dose of hydroxyurea, and that dose is sort of arbitrarily defined as being at least 2 grams per day, or in a bigger person, 2.5 grams per day, and your platelet count remains above 600,000. Or in the second and third examples, the patient is developing leukopenia or anemia while the platelet count still remains elevated. The third criteria is basically toxicity from hydroxyurea, most commonly leg ulcers or other mucocutaneous problems, and the fourth, hydroxyurea-related fever. So when these criteria were proposed, they were then studied in a follow-up paper and looking at the characteristics and the prevalence of hydroxyurea resistance and intolerance. And so this paper looked at 166 patients who had been treated with hydroxyurea for a median of 4.5 years. And within that group, 20% met at least one of the ELN criteria for resistance or intolerance. And within that 20%, those who were hydroxyurea resistant, but not intolerant, only the resistant group, had an increased risk of death and higher incidence of myelofibrosis. And that is shown here. In terms of overall survival, the hydroxyurea resistant patients clearly did worse. And so this seems to indicate that that subset of patients is a little bit of a different slice of the pie of patients with ET. They do worse and perhaps need to be taken a little more seriously. So, when you're considering alternatives to hydroxyurea, let's go through the options. So anagrelide. So I'm sure many of you are familiar with the PT1 study in which patients were randomized to treatment with either hydroxyurea or anagrelide. 800 patients in this study, and they could have been treated previously with hydroxyurea prior to inclusion in the study. But the primary endpoint, which was a composite of arterial or venous thrombosis, serious hemorrhage, or death from any of these causes, hydroxyurea was superior. This graph showing event-free survival, with the hydroxyurea group being superior to anagrelide. And then breaking out into the individual endpoints, which is probably hard for you to see, but if we go through these really quick, arterial thrombosis, hydroxyurea was superior to anagrelide. But venous thrombosis, if anything, anagrelide was superior to hydroxyurea. Bleeding events, hydroxyurea was superior, and myelofibrosis transformation, hydroxyurea also was superior. So this has really been the fundamental basis by which, by most recommendations, people would favor hydroxyurea over anagrelide as first-line therapy for high-risk ET. One point as well from this study is that patients treated with anagrelide had a higher rate of discontinuation from treatment. So you can see here 148 of the patients versus 79 in the hydroxyurea arm, and the majority of this was due to toxicity, and the majority of that was due to cardiovascular side effects. So while I think in general anagrelide is relatively well tolerated, there are these potential toxicity issues that could limit its use in some situations. In another study, the anhydrite study also compared hydroxyurea to anagrelide, and this study was a little bit different from the PT1 study. It was a non-inferiority study, so a little bit different in design, and there were 36 months of follow-up, and no patients had transformed to myelofibrosis or AML at that point. And that may be in part because the study enrolled only patients who had been previously untreated, so they were really early in their disease course. In this study, essentially, no difference was found between the two groups. Again, keep in mind it was a non-inferiority study, but I think it just adds to the literature to consider that, again, in many patients, anagrelide is still a reasonable option. Okay, so we'll talk briefly about interferon. So pegylated interferon, as covered in detail by Dr. Silver yesterday, is definitely an option for the different myeloproliferative diseases, and specifically in ET, through a couple of different studies, has shown activity both in terms of a hematologic response. So on the left here, you can see that about 3/4 of the patients with ET treated with pegylated interferon actually had a complete hematologic response. And we also see molecular responses. This is true in ET, it's true in PV as well. In some cases, even complete molecular responses. So this is different than many of the cytoreductive agents, such as hydroxyurea and anagrelide, where it's very unlikely you'll see something like this. Toxicity remains an issue even with the longer-acting forms of interferon. Here in this study, you can see that there were a smattering of patients who had grade 3 toxicities, including neutropenia, diarrhea, or elevated LFTs. A practical issue also is access to pegylated interferon. For some patients, insurance coverage can be problematic. But certainly in a specific subset of patients, it's reasonable to consider interferon. Some would propose that this drug is so effective that we should consider it as first-line therapy for high-risk ET. And in fact, there's a phase 3 study that's been conducted by the MPD Research Consortium attempting to answer this question in ET and PV, and that study is currently ongoing. There's another study looking at another form of pegylated interferon, which is given only every 2 weeks, and that study is also ongoing. So the role of pegylated interferon continues to evolve in ET. Okay, so busulfan. This is a drug that I think in a lot of ways has seen a little bit of a resurgence recently. I think it has the specter of many of the cytoreductive agents of increasing leukemic risk in patients with myeloproliferative diseases. But a number of studies have come out over the past several years suggesting that busulfan has substantial activity in ET, and that perhaps the risk of secondary transformation is not as high as was once believed. In the first study above here, you see that 36 patients greater than 60 years old were treated with busulfan. There are actually no cases of AML at a median follow-up of 72 months. In the second study, a relatively small study, but there was the vast majority of patients experienced a complete hematologic response, as well as some who had molecular responses. Note, however, there were several cases of transformation to either AML or MDS. And then the Mayo Group published a paper recently with their experience with busulfan in both PV and ET, as well as myelofibrosis. And of the 37 patients with ET, there was one patient with leukemic transformation, but that patient had also been treated with P32. So I think while many hematologists would remain nervous about using busulfan in a younger patient with ET, for elderly patients, particularly if you've exhausted other treatment options, this is something that can be considered. Okay, so what's the actual data for JAK inhibitors in ET? So the extent of that really is from this phase 2 study with ruxolitinib in patients with ET who were either refractory or intolerant to hydroxyurea. And this is a study that included both patients with ET and PV, but I'm just going to show you here what was presented at ASH in 2014, specifically in patients with ET. So there were 39 patients with ET enrolled in this study. You can see the baseline demographics here. I guess a couple things to note. As expected, virtually every patient had an elevated platelet count, and almost every patient had a platelet count above 600 at entry into the study. Splenomegaly was present in only 4 of the patients out of the 39. And as you can see here, there were a variety of different treatment options that have been used prior to entry into the study. About 64% of the patients were positive for JAK2, so that's more or less what you would expect from the normal distribution of ET. And at this presentation, the median exposure to ruxolitinib was about 4 years. This is a pretty long-term follow-up of this study, and you probably can't see the numbers here, but these graphs are showing on the top, the platelet count, in the middle is the white blood cell count, and the bottom is the hemoglobin. As hopefully you can see that the platelet count, of course, started out high and then decreased quite rapidly and then kind of stabilized and plateaued with a median platelet count about maybe 450 or so. So the platelet count definitely went down. Does not go down, say to 200 or whatnot, but it certainly goes down with treatment with ruxolitinib. The same is true with the white count. It goes down a little bit and then kind of stabilizes, and the same is true as well with the hemoglobin. Now, this has to be factored in considering the doses of ruxolitinib that were used in the study, and I'll have a slide on that coming up, so we'll discuss that. Here is the response to ruxolitinib broken out a little bit differently. Here, looking at patients who had an elevated platelet count, basically, essentially a platelet count greater than 400 at baseline, and then the percentage who had a platelet count below 400 at any given time. And here is shown at 12 weeks up to 192 weeks. So certainly there is a proportion and an increasing proportion as time goes on of patients who achieve that, although it's a relatively small subset of those patients. If we use a little bit less sort of stringent criteria, we say, well, those who had a baseline platelet count of greater than 600, and let's at least get it below 600, now you see that about half of the patients were able to achieve that. So again, it clearly has some activity against the platelet count. It does reduce it. It doesn't necessarily bring it all the way down to normal. In terms of the white blood cell count, again, you see a decrease over time, and the same is true for those 4 patients who had splenomegaly. Basically, most or all of those patients, their spleen became non-palpable throughout the study. In terms of symptoms, very analogous to what has been observed in PV and myelofibrosis, symptoms tend to improve significantly in patients with ET treated with ruxolitinib. And that's shown here, and the graph is looking at the dark green bars are those who had 100% improvement, so that symptom went completely away. And then the light green is 50 to 100% improvement. And so you can see across the board for itching, bone pain, night sweats, et cetera, there was substantial improvement. Okay, so talking about the dose of ruxolitinib, this is a little bit complicated in part because the way the study was designed was that the first phase was a dose-finding stage, and so patients were randomized to 3 different doses. I believe it's 10 milligrams BID or 15 or 20, and then 25 milligrams BID actually to start. And then after the first 8 weeks, the doses could be individually titrated. And then after the first 20 or 25 or so patients were enrolled, it was decided to focus on a dose of, I think it was 20 or 25 milligrams BID as the starting dose for the remaining patients in the study. So, again, it can be a little difficult to interpret in terms of what doses they were on, particularly early on. But I think if you just look at the furthest follow-up here, 192 weeks, and another point I should mention is that at about that time period, about 60% of the patients remained on treatment with ruxolitinib. So the distribution of the total daily dose of ruxolitinib at that point, 39% of the patients shown in blue were in the 30 to 50 milligram range, so 20 milligrams BID would be in that box. And there was certainly a variety of doses, but they're reasonably high doses. So you're not talking about, in general, patients on 5 milligrams BID. So in comparison to PV and MF, you do need a relatively high dose of ruxolitinib to get that kind of response, it seems. Okay, so in terms of toxicities, nothing particularly surprising here. You see that the most common adverse event was increased weight, and that's, again, analogous to MF, with the exception that in myelofibrosis, our patients often come in with, let's say, a 20, 30, 40-pound weight loss, and then they put it all on, or most of it back on, and then they complain because they didn't want to put it all back on. Here, they may not have lost as much weight, and they actually really are mad because they might be gaining significant weight. But otherwise, the side effects are relatively modest. There were some infections reported, including bronchitis, but again, nothing super surprising compared to our experience in the other myeloproliferative diseases. Okay, so very briefly, other options, other JAK inhibitors. So it hasn't really been anything published, but there have been other studies with JAK inhibitors in ET. So fedratinib, which was the Sanofi compound, was explored in a small study in ET, and that study was closed due to lack of efficacy. And the same was true of a study, phase 2 study with momelotinib in ET. That arm was closed due to lack of efficacy. So at this point, as far as JAK inhibitors, ruxolitinib is the only potential viable candidate, at least to move forward for ET. I also want to note that imetelstat, which is now being examined more so in MF, was studied in a phase 2 study in ET, and in that study there was clear activity with durable hematologic and molecular responses observed, but because I think of the overall toxicity of imetelstat and strategic decisions by the company, they are not planning to develop it further in ET at this time. Okay, so back to our case. Again, this is a 72-year-old guy who has a platelet count of 1 million, JAK2 negative, calreticulin positive. He's been treated with hydroxyurea, developed anemia, and then had worsening headaches and palpitations with anagrelide. So let's see if you have the same choices here based on what I've showed you. So you can put in your revised options here. Okay, so right or wrong, you pretty much stuck to your guns, pretty much, and I think this is not a black or white question. That's not necessarily a right answer here, but just to elaborate on this a tiny bit. So pegylated interferon, as I showed you and as you know, has clear activity. Two potential issues to make you hesitate a little bit here. One, the guy has a history of depression, and we know that can be a problem with interferon. And two, he's already older to begin with. So those two things in combination, I think, would make some people nervous about using interferon here. Busulfan, could be an option. He's 72. No one's particularly excited about that. Hydroxyurea, yeah, I mean, you could fiddle with the dose. Maybe you'll tolerate an anemia with a hemoglobin of 10. That, I think, is still an option potentially. And then ruxolitinib, it would certainly be off-label, and the data I've showed you so far is with a small study with 39 patients. So it certainly would be nice to have more data before we would use that commonly in ET. So to wrap up, just to summarize, as I've covered, hydroxyurea generally is considered the first-line therapy for high-risk ET, but there are several alternatives. The role of anagrelide interferon continues to evolve. There are certainly a subset of patients with ET who have true hydroxyurea intolerance or resistance. And JAK2 inhibition is definitely a viable strategy to consider, but we would certainly like to have more data on that as going forward. All right, thanks very much.